So I want to switch gears, but I do want to touch on something that Dr. Golden brought up, which is really important, which is the stigma that's associated with a lot of the conditions that we're talking about today. So I think diabetes being one of them, heart disease being another. A lot of times, people that are diagnosed with these conditions just feel like other people are looking at them as, oh, I must have eaten badly, or I must have, done something wrong. I must have been a couch potato and not exercised enough, and that's why this is happening to me. And I think that that's something that society as a whole needs to address, that there's so many different factors that go into people's individualized risk, and that genetics plays a large role in a lot of it. So that brings us to our next topic, which is heart health and diabetes, and we'll sort of touch on more of these. So let's start with some scary facts so that I know that I have a captive audience. So heart disease is the number one killer of both men and women in the United States, period. So that includes diabetics, that includes non-diabetics, that includes, just about everybody. More than any cancer combined, all of the cancers combined, heart disease is the number one killer. It affects people with diabetes at a younger age. So this is particularly important when we talk about women, because back in the day, heart disease was thought to be a man's disease because it affects men first, right? So it affects men about 10 years earlier than it affects women, because women are protected until menopause. But all bets are off when you're a diabetic. So I can't tell you the number of times that we see diabetic women who are young, in their 40s and 50s, who come in with heart disease because, it sort of trumps the protective effects of hormones. The longer that someone lives with diabetes, the higher the chances that they'll develop heart disease. Diabetics have a 2 to 4-fold increase in the risk of CAD or PAD. So CAD is coronary artery disease, which is what we're going to be talking about now. And peripheral artery diseases, primarily we're talking about the arteries in the legs, and that's what you're going to hear about from Dr. Parikh in just a few short moments. Diabetes is a coronary risk equivalent to known CAD. So this is something that we used to say a lot, and it's not entirely true anymore. What that phrase means, a coronary risk equivalent, is essentially that somebody who's a diabetic is as much at risk for a heart attack as somebody who's already had a heart attack, which is a really scary way to say that, but it's not entirely true anymore, right? So it's still true for about half of women, 2/3 of men. And the difference is probably that over the past 15, 20 years, preventative therapies, particularly statins, have become so much more widespread. And so, it's not as much of a risk factor, but still diabetes is a major cardiac risk factor. Diabetics are more likely to have multivessel coronary artery disease. So if they have heart disease, it's more likely to affect multiple different vessels. And diabetics have a heart attack, they have a worse prognosis afterwards. So why is it that what's happening in the diabetic person that's making them more prone to heart disease? Let's go over a little bit of the pathophysiology of it. And what it is atherosclerosis. That literally means hardening of the arteries. And I think this is a really important graphic because it gives us a lot of information. So if you look all the way on the left, that's the smooth inside of a normal blood vessel, right? And then over time with either poor diet or risk factors, you get the fatty streak, and then you get a little bit of plaque, and then the plaque increases. And it's something that's happening over time, just because of a milieu of risk factors and, predisposition to atherosclerosis. And this could be age, this could be a number of different factors. But just having plaque is not actually clinically significant, right? So this is the plaque that you have that's not actually going to cause symptoms. You're not going to feel it. You're not going to know it necessarily unless you look. And the only way to look is by doing either a CT scan, which has radiation and contrast, or a catheterization, which has contrast and a procedure, right? So a lot of times this is assumed based on a person's risk. And the only way that we sort of treat this, or not the only way, but when we know that this exists, we're much more aggressive about preventative therapies like aspirin, like healthy lifestyle, like statins, right? These small plaques, right, the 20-30% plaques that we're talking about here, don't show up on stress tests because, again, they're not clinically significant. It's just a precursor to heart disease to come, right? Then over time, if left unchecked, it can progress to obstructive plaque, and that's when it becomes significant. And we use when we talk about the heart arteries, we use a 70% cutoff. So something that's more than about 70% usually that's where it starts to cause symptoms. So that's when somebody's exerting themselves, they feel some chest pressure, they stop, it goes away. That's when an obstructive plaque. That's when the stress test becomes abnormal. That's when it usually becomes clinically significant. And then if again, when it causes a cardiac event, so a heart attack is what we're talking about, that it's when that plaque ruptures and causes a clot in the blood vessel, right? So this kind of gives you a very nice overview or a glimpse at the progression of atherosclerosis throughout, sort of a lifetime, and then the end result. And like I mentioned, atherosclerosis is actually a systemic disease. So it affects not just the arteries in the heart, but all of the arteries in the body. And so we kind of group these vascular complications into two buckets, right? Microvascular complications, which are basically the small arteries that supply the eyes and the kidneys, and those are actually affected by glycemic control. So if you can control your sugar and get it into, an almost normal range, you can limit the amount of microvascular complications. That's not so much the case for the macrovascular complications, the large arteries that we're talking about today. So heart disease, peripheral disease, carotid disease, it's something about plaque in diabetics that's just not the same as plaque in non-diabetics. So this chart actually gives me like PTSD from medical school. So don't look at it for too long. It's just meant to be just to give you an idea of how complex the interplay is amongst a number of different factors, which leads to abnormal. It's called endothelial dysfunction, right? So, and the endothelium is the lining of all the blood vessels in your body. And so there's something that not only in diabetes, but in other, risk states, that you have endothelial dysfunction, which just makes your blood vessels more prone to inflammation and more prone to plaque formation. And then on top of that, diabetic plaque is also the more unstable plaque, more prone to rupture and leading to a cardiac event. And then, unfortunately, the other bad news is that cholesterol is also something. When you're a diabetic, your cholesterol is also affected. So the good cholesterol, the HDL, the protective effects are less. So the good cholesterol is not as good, and then the bad cholesterol is even worse in diabetes. And a picture is worth 1,000 words. So let's just compare. This is not meant to be subtle, right? So on the left, you see what normal coronary arteries look like. And it's just to get a visual, right? So large caliber vessels, nice and smooth on the inside. And then on the right, it's something that we call, sort of the diabetic blood vessels, right? So the lumpy, bumpy blockages in multiple different areas of the blood vessel, very small, tiny, tapered blood vessels. And so it just gives you an idea of the sort of widespread effects of diabetes. This is not meant to be scary. And so how does that manifest? So if somebody, when you do lead to that obstructive plaque, when it becomes clinically significant, how may that present? And certain subgroups, diabetes being one of them, but also women and also the elderly can present differently, right? So you're more the sort of classic chest pain story, typical angina is substernal chest pressure that's brought on by exertion or by stress and relieved with rest or nitroglycerin. That's the definition of typical angina. So, these subgroups are more likely to have either atypical angina or just not have chest pain at all and present either with, GI discomfort, nausea, vomiting, indigestion, abdominal pain, lightheadedness, general weakness. It's just something about not feeling quite right. And so we made this slide actually when we were talking about women, but this is very applicable today as well, right? So different matters. When there's just something about it, when you talk to people who have, heart attacks but didn't present with chest pain, it's just something about feeling different that brought them to the emergency room.